Welcome to the deep dive. Today, we're really getting into the thick of it, looking at a major structural conflict in global healthcare. We're talking about the Trump administration's most favored nation, or MFN, drug pricing policy. And, well, the huge reaction it's provoked from the big global pharmaceutical companies. Multi-billion-dollar reactions, really.
Yeah, it's definitely more than just politics as usual. This is a fundamental shock to the system, to the whole innovation business model.
Yeah.
So our mission today is to look past the headlines, understand the nuts and bolts. We need to talk about generics versus new drugs, the super complex U.S. insurance setup, and what these companies are actually doing in response.
Absolutely, because the core issue here is just massive uncertainty. Pharma needs predictability, right, to fund R&D, and MFN throws a major wrench in that. Okay, let's unpack this pressure. It all started back in May 2025. That's when President Trump announced the executive order, Most Favored Nation Pricing for Prescription Drugs. The goal itself is, well, it's bold, kind of revolutionary for the U.S. system.
It really is. The ambition is remarkably simple on the surface. The U.S. government aims to buy certain drugs at prices no higher than the lowest price paid by any comparable wealthy nation, any OECD country. The argument from the administration is straightforward. Why should U.S. patients pay so much more, effectively subsidizing lower prices elsewhere?
And the teeth behind it, that's what makes it really bite. There's this threat, this mechanism allowing up to a 100% tariff on drugs if companies don't play ball and lower their prices. 100%. I mean, that sounds less like negotiation and more like, well, a declaration of war on their pricing structure.
It's definitely a hardball tactic, and what's really interesting is how it borrows this term MFN from international trade. Usually MFN status means you give a trading partner your best tariff rates, the lowest ones. We've seen it historically with like tariffs on Chinese chemicals. But applying that kind of aggressive trade tool directly to drug prices within the U.S., that's pretty novel. It shows how determined they are.
Okay, so to really get why this causes such a panic, we need to look at the U.S. drug market compared to, say, other places. In countries like Japan, you've got public health bodies setting or negotiating prices. Here, it's much more the Wild West free market, negotiation, supply and demand, and that leads to these two different worlds for drug pricing.
Exactly. You've got the brand new drugs, the originators, they have patents. And during that patent life, the prices are high, very high. That's supposed to cover the massive R&D costs, billions sometimes, and incentivize companies to develop the next drug. But then the patent runs out.
And the generics arrive?
Yep. The generics hit the market, competition ramps up, and prices crash. You can see a drug go from costing thousands a year down to maybe just a few hundred. It's a dramatic shift.
And that difference is absolutely key here. The MFN policy as it stands now is aimed squarely at those new patented drugs. The generics, the ones already cheap because of competition, they're currently off the hook from this specific MFN pressure.
Which brings us right into the maze of U.S. health insurance. Since there's no single universal system, it's fractured. You have Medicare, mainly for seniors, mostly dealing with generics. Then there's Medicaid, the public insurance for lower income folks. And critically, it does cover some of these expensive new drugs. And then the biggest piece by far is private insurance, usually through employers.
Okay, so here's where the MFN rule lands first. The initial negotiation target is specifically the price of those new drugs paid for by Medicaid.
And you can see why when you look at the spending. For Medicaid, something like 85% of the prescriptions filled are for generics, cheap generics. But those generics only account for about, 16% of Medicaid's total drug spending? It's that small fraction of new, pricey drugs that eats up most of the budget.
But that makes you ask, okay, if MFN is this huge lever, why start with Medicaid? It's a significant program, sure, but not the whole market.
Well, context is key here. Medicaid's total drug spending, while large in absolute terms, is maybe only 10% of all U.S. drug spending. The private insurance market. That's the other 90%. That's where the real volume and revenue are for drug makers. So hitting Medicaid first feels like, well, maybe a test case. It lets them flex the MFN muscle, see the legal challenges, watch the corporate reaction without blowing up the entire market right away. It builds pressure.
And that huge private market, that 90%, that's where we find these really powerful middlemen everyone talks about. Pharmacy benefit managers, PBMs. These are the companies working for insurers and big employers, negotiating drug prices behind the scenes for most working Americans.
Right. And their main tactic, demanding huge rebates, basically discounts, from the drug manufacturers. But their real power, their leverage comes from controlling the formulary. That's the list of drugs the insurance plan actually prefers or covers. If a PBM leaves your drug off their formulary, Millions of patients suddenly can't easily access it. That threat forces manufacturers to pay those big rebates.
Yeah, we've all probably known someone whose regular prescriptions suddenly changed because their insurance formulary shifted. That's the PBM at work. And of course, how those deals are struck, how big the rebates are, it's completely non-transparent. It's a black box. The administration has made noises about PBM transparency, but for now, the MFN focus is squarely on the public Medicaid program. The PBMs are feeling the heat indirectly, maybe, but not directly from MFN yet.
So faced with this pressure, how are the companies reacting? It's fascinating. On one hand, you have compliance. Two giants, Pfizer and AstraZeneca, agreed relatively quickly to provide their drugs to Medicaid at these MFN-level prices. AstraZeneca actually went a bit further, saying they'd work to align their U.S. prices more broadly with other countries.
But then Pfizer did something really unexpected, really disruptive. They launched a website, trumprx.gov. It's a direct-to-consumer site, DTC. Basically, they're trying to bypass the whole system, the insurers, the PBMs, the pharmacies, and sell directly to patients. And they're offering big discounts, apparently averaging 50% off the list price, sometimes way more, up to 85%.
It's a bold move, trying to solve a specific problem we'll get to. And Pfizer's backing it up with serious investment. They announced a huge $7 billion plan for new manufacturing in the U.S. Yep. Now, building factories here is seen as a strategic play. The thinking is, maybe if we make it here, we can argue against those import tariffs being threatened by the MFN order. And this idea, bringing manufacturing back onshore despite higher costs, we're seeing other global pharma companies starting to explore that too.
Okay, but all this talk of lower prices, MFN prices, discounts, it leads to the big elephant in the room, right? The huge frustration for patients. The list price the manufacturer sets is almost never what you actually pay out of pocket.
Exactly. This is the critical complexity. That final price you pay at the pharmacy counter, it's got layers added on. The PBM takes a cut, the wholesaler adds a margin, the pharmacy has its service fees. And these are often calculated based on that initial list price. So here's the worry. Even if MFN forces the manufacturer's list price down, if all those middlemen just keep adding their usual markups and fees, the patient might not see much savings at all.
So the savings could just get absorbed somewhere in that murky supply chain between the factory and the pharmacy counter. The policy could just shift profits from the drug maker to the middlemen, not to the actual patient.
That's the core risk. And that's precisely why Pfizer's TrumpRx direct-to-consumer site is so interesting. It's their attempt to cut out all those intermediate steps. Sell directly, offer a transparent discount off the list price, and hope that translates into real savings for the patient.
But building essentially a national mail-order pharmacy from scratch, that sounds incredibly difficult. Logistically, I mean.
Oh, it's a nightmare. A huge operational challenge. You need systems to verify prescriptions legally in all 50 states. You need complex logistics, especially for drugs needing refrigeration to cold chain. You need nationwide distribution. They're trying to replace decades of existing infrastructure with basically a website and warehouses. So whether TrumpRx can actually work at scale, that's still a massive question mark.
Okay, so looking down the road, what are the key things we need to keep an eye on? What determines how this all shakes out?
Well, first and foremost, does MFN expand? Does it move beyond just Medicaid at initial 10% and try to impose these prices on the much larger private insurance market? If they try that, forcing MFN onto the 90%, that's when you'd likely see massive industry pushback. It would be seen as, an existential threat to their revenue model. Compliance would be very unlikely.
Okay, what else?
Second, does the pressure spill over? We talked about generics being exempt now, but will the intense focus on new drug prices somehow disrupt the generic market? Generics run on thin margins. Any added complexity or pricing pressure could potentially affect the supply of basic essential medicines. That's a worry.
And the company responses.
Third, how well do these countermeasures work? Specifically the DTC model, like TrumpRx. Is it sustainable? Can they overcome the huge logistical hurdles? Or will the cost just be too high? And fourth, related to that Pfizer investment, how real is this shift to domestic manufacturing? Building factories is one thing, but it costs more here, and you need skilled workers. How much production will actually move back?
And we can't forget the international angle, the trade and tariff part. Where do things stand there?
It's messy. Japan and the EU seem to have landed at a 15% MFN tariff level for now. The UK and South Korea are still apparently in negotiations. China faces high tariffs generally. But interestingly, India, a huge source of generic ingredients APIs, seems exempt for those, but not for APIs used in new patented drugs. It's complicated.
Wow. Okay, so wrapping this up, it really touches everything. Healthcare access, trade policy, corporate strategy. It's incredibly complex.
It really is. And it's crucial to understand the structure behind the headlines. This isn't just about lowering a price tag. It's about potentially changing the whole engine of medical innovation.
Yeah, because while everyone in the US wants lower drug prices, more like other countries, if you push too hard too fast, the risk is that companies might just say, you know what, the US market isn't worth the hassle anymore, and pull back on launching new drugs here. That could hurt patients waiting for treatments.
Exactly. Finding that balance is the ultimate challenge. How do you set prices so that drugs are affordable and accessible for patients today, while still making sure there's enough incentive, enough funding for companies to research and develop the breakthrough cures we need tomorrow? That tension, that balance, that's what we'll be watching for years to come.